Hello and good evening. Welcome to our today's CME. I'll be your host for tonight. My name is Dr. Kilonzo, and I welcome Alice and her team all the way from the US to talk to us about low back pain and how they manage it out there. Alice and colleagues, welcome to Kenya through Zoom.
Thank you. Thank you, Peter. Thank you, Dr. Kilonzo. We're delighted to be here. And isn't it amazing what Zoom enables us to do, which we wouldn't have imagined a year or two ago?
Okay, welcome. And I think we can start now.
Okay, I will share my screen in a minute. So everybody, just introducing myself, and then Alex, my colleague. So we're going to, can you see the right? Yeah, you've got that one. Let me put that over there. Hang on, let me get rid of that. So I can't see you, but that's okay. Alex can. So welcome everybody. It's really kind of you to invite us to deliver this CME for you today. Many of you won't have met me, but I think some of you probably have. So I've been coming to Kenya now for a decade. Unfortunately, I really miss it. Didn't get to come last November because of the COVID pandemic. But I have been coming with a trauma and orthopedic team to Kenya. And we've been up and worked in Nyahururu and Marsabit, Nanyuki, Mombasa, Kitale. So I'm sure many of you have heard of our work through Future Health Africa and Trauma Team. Back here in the UK, I am a private practice physiotherapist specialising in MSK, but I also lecture in postgraduate medical education at the University of Plymouth, running a programme in global health. And then Alex will, I'll introduce, Alex is going to join us in a bit. He's here, he'll contribute a bit later. So I've asked my colleagues like Alex to be involved because he's what we call here in the UK an extended scope physiotherapist. And whilst we're talking about back pain to you, this is something I want to introduce to you, and the concept of spinal pathways for how you look after your back pain within Kenya as well, because I'm very aware from the clinics that I've been involved with, the huge burden of back pain and musculoskeletal pain, you know, in your clinics and in Kenya. And Alex works as an extended scope physiotherapist at our local hospitals trust. So it's a great opportunity to talk about this because actually I hadn't actually realised that 2021 is the global year about back pain, according to the International Association of the Study of Pain. And then I've just put our two logos down here for physiotherapists in this country in the UK, because I think it might be relevant. And there's a question to you about the autonomy really of your multidisciplinary team in Kenya. So we here in the UK as physiotherapists are autonomous practitioners, able to make our own decisions on patients and decide our own treatments. And we are registered with the government as health and care professions council, and obviously have standards that we legally have to adhere to. So that might have an influence on what you feel you can or can't develop POs or multi-professional team over. So I'm going to go through a few slides. And then hopefully we'll have lots of time for conversation and questions at the end. And I've been deliberately put some things in here to hopefully make you think and to raise discussion rather than this just being a sort of output of you know, definitive stuff. So very briefly, we all know this, but at any given point, 577 million people have low back pain. So an estimated 80% of the population in the developed world particularly. But the latest global burden of diseases study for low-income countries or middle-income countries is that low back pain is, you know, now becoming one of the leading causes of years lived with disability. So obviously it's not sort of mortality, but it's about the years lived with disability, which is incredibly difficult for the individuals and causes all sorts of sort of socioeconomic issues and fills up our clinics. But the global point prevalence of sort of activity limiting low back pain for more than one day is about 12%. So a huge amount of it gets better quite quickly, but obviously there's 12%. So this is just a little slide of when I'd asked Dorcas what you wanted us to talk about. So it's quite a big list, but sort of obviously acute back pain with no surgical indication, an essence of things such as bed rest, physio, which exercises, what machines, lumbar corsets, home exercise program, and then obviously sciatica and low back pain. So we'll hopefully, I won't be covering it in that order, but hopefully we'll cover that during the course of this evening. So my plan for the session is really to give you an overview of a considered physio approach to low back pain and sciatica from where we stand here, acute, subacute and chronic. And I've presented this through a series of case studies actually, hopefully therefore to promote discussion and sort of demonstrate to you our thought processes and our clinical reasoning. So using some of the evidence-based practice, these nice guidelines, clinical knowledge summaries, and I can make sure I send to you all the links afterwards. These are available open access online. So NICE's National Institute for Clinical Excellence here in the UK, and sort of integrates evidence-based practice into clinical output. And then, as I said, it's sort of almost highlighting a concept of physiotherapy triage for low back pain and the role of what we are as extended scope practitioners. And then using these case studies to introduce the spinal pathways present here in the UK, and maybe to pose a question of how you feel you might be able to develop these sorts of pathways of care within Kenya. So my very first case study is actually a patient I saw in Kenya, in Marsabit, 2 years ago. A 28-year-old male came in. He was quite a skinny lad, BMI of approximately 22. He was seen by myself as the first sort of contact with a clinician. He had hip pain, he had a shifted posture, he had a long leg on his painful side, which if it was real hip pathology, you'd maybe expect the short side to be the painful side. So that set me sort of alarm bells ringing, a bit confusing. His pattern of symptoms didn't add up. And he had a slight change in straight leg raise when I sort of moved him around a bit, a few rotational exercises, but ultimately quite a confusing picture. So I decided to ask for a medical review, which was initially a UK consultant who agreed with me that it was a bit confusing. And then we asked Dr. Nadanya, who I know is not able to be here this evening. And this is where I learnt a huge amount, because we sent him up for a full spine X-ray. Obviously, with the financing system of your X-rays, the patient came back having had lumbar spine only because he couldn't afford the full spine X-ray. Unfortunately, at this point, Dr. Nadanya said, actually, this is a citizen of Kenya and he needs this X-ray, and sent him back for the thoracic X-ray. And sure enough, back came TB, thoracic spine. And I guess the patient, you will know more about this than me, but the patient, the connecting structure between the hip, which is ultimately where the patient came into clinic with, and the thoracic spine is probably the psoas muscle, which had gone into a huge amount of spasm, and hence, what the patient complaining of was hip, but actually it was TB spine. So with everything that we're saying this evening, and the reason that I've put this case in first is twofold. One is that we can talk to you about pathways of spinal care, but based on our pathology that's normally here in the UK. And you do have in Kenya a higher risk of infection from brucellosis, obviously from TB, and potentially other aspects of infection. So although our guidelines and pathways will be of some use, obviously it's really important to consider the local context, and I hope I've worked with you enough to understand that to a degree. And then I did find out that spinal TB is the most common MSK, musculoskeletal manifestation of the TB infection, affecting 1 to 2% of all cases based on the evidence I could read. But I think the other question I have to you, based on your care and your clinics in Kenya from this, is that in trauma team, I know some clinicians who've worked with me in Kenya are quite surprised that I, as the physiotherapist, can be running clinic, especially when all our surgeons are in theatre, as the frontline first clinician. But I think we very much have that as a practice here. We are trained to spot what we call red flags. So when we, as long as you're very aware that your clinicians can spot red flags and know when to come and ask for help, physiotherapists or the orthopedic technologists, or even some advanced practice nurses could very definitely be the frontline clinicians that act sort of as triage if you're feeling that you're getting, you know, quite swamped with patient numbers. So obviously red flags, as we're all, this is how we title them in the UK, obviously I'm not quite sure, but you know, fractures, infection, cancers, other visceral structures, cauda equina, rheumatology. It's just ensuring that your whole MDT know about them, which I'm sure you do, but if they do, then that essence of the MDT multidisciplinary team being able to be the first contact clinician, and that's really a question I sort of put out to you, is do you feel you've got that faith and trust in that knowledge, and you know, can that then be utilized in the sense of developing a pathway for you? And I've picked up other stuff in clinic before, you know, definite cauda equina symptoms that I've sent up to emergency department. I've picked up a pneumonia that came in as a sort of lumbar spine pain, you know, and obviously the rheumatological conditions can come in, and actually you're the first person to spot that it's a systemic illness rather than just a pure back pain. So just moving on to case study 2, and I'm going to ask you to put stuff into the chat at this point. My colleague Alex is actually going to monitor the chat, and I can't see anything. So if anybody does want to raise a hand or speak, please, Peter, just if you could keep an eye on that. So this was a patient who's came into me actually last week, which is why it's here. So she's a 36-year-old mum. She's her daughter is 11. She works from home, and particularly during COVID has worked from home via a computer, usually sitting on a fairly soggy sofa. She's gained 10 kilograms in weight through lockdown. She used to go to the gym quite a lot. Having said that, her BMI I'd now say is approximately 27. So she's not hugely obese, but had definitely gained some weight. So pain worse with sitting, rising from sitting, no red flags. Some sort of posterolateral quadrant ache, so quite common obviously for back pain, for a few days, and then 1 week of intense pain, unable to move, and she had to crawl from the bed to the toilet. So she self-administered paracetamol, but wasn't keen for naproxen, which is the NZ of choice that we use over here at the moment. And it sort of gradually settled, now back to most movements and most activities. And she came into clinic 6 weeks later for advice and preventative exercises. So I'm going to try and find my chat here. So just very briefly, what I'd like you to put in is whether or not you would want to image this patient. Purely a yes, no answer. Jolly good. So lots of no's, which I personally would agree with. I definitely didn't feel I needed to send this patient for imaging. On range of movement, she was slightly tight, very mildly reduced straight leg raise, but everything neurological was normal. Oh, hi, Dorcas. I see Dorcas is here on the chat, which is great. So I gave her education, lifestyle, advice on exercises, on obviously to take the analgesia as she needed to. And I did actually advise sort of including the use of naproxen if she gets that acute pain again, just for a few days. And then the other thing I think, and we'll talk about this, is that essence of, I actually taught the patient that sense of, not the because obviously we ask the questions about bladder, about bowel, about sensation between the legs, and really reassuring her that if this happens again and she gets this acute intense pain, feels she can't move, as long as she can actually spend a penny or doesn't have any urinary retention, as long as she can feel between her legs, doesn't have, actually don't panic, keep moving, allow it to settle, and you will almost certainly get better in a few days. So I don't think it's bad to advise patients on, as long as this doesn't happen, actually don't worry, it will get better, and feel reassured. And so she's gone away off to do her own things. So, and I think that sense, just coming here to, these are a couple of definitions of pain. You know, an unpleasant sensory and emotional experience associated with actual or potential damage. And I think it's that associated with potential. It's not a definitive descriptor of damage is quite key. And then I think actually the second one is even more holistic, pain being a sort of mutually recognizable somatic experience that reflects the person's apprehension of threat to their body or existential integrity. And actually what this lady had said to me is how scary it was, you know, not being able to move, not quite knowing what was happening. And actually what she needed was that sense of reassurance that it would get better. And she didn't need me to start spending hours, you know, telling her what structure I felt might or might not be wrong based on imaging or my best guess. But it was that reassurance that, yeah, actually, if you do these things and if you keep moving and if, you know, then ultimately, you know, this is actually a relatively normal experience for somebody to go through at some point in their life. And I think that sense of communication and the words that we use cannot be overestimated in how important it is. I've picked up many a patient sort of not quite off the meritorical floor who've sort of said, oh, you know, somebody's told me I've got a disc squished or my bones are crumbling or I've got degenerative changes. And patients just don't, these words terrify them to the point of sort of catastrophizing or making their pain more chronic than it necessarily needs to be. And I think a huge part of back pain and acute back pain, it's not us needing to know more or less about the anatomical structures or about the pathology, but it's actually about our wording and our time with the patients to explain and mainly reassure them, you know, an awful lot of the time. Because as I'm about to show you, but sort of we are aware that the structural abnormalities that appear on, particularly in MRI, often don't correlate with the pain. So this table is from a paper by, I think he's Scandinavian with that name, Brzezinski, or actually might be in the States, but with a name I can't pronounce. But there was a study done, this is a systematic review of some literature where they actually looked at the number of reportings of spinal MRIs that had reportable imaging findings in the patients or in the cohorts that were actually asymptomatic. So as you can see, there's obviously it increases as you go up the increasing years, but even in a sort of 30-year-old, there's the signs of disc degeneration on almost 50% of the population that are, you know, asymptomatic, so don't have a clinical picture to fit that. And whether that's a little disc bulge, whether it's a protrusion, and obviously slightly increasing. But I think it's really important for us to just remember that. And I do see when I'm in patient, you know, in Kenya particularly, but it does happen here as well, that our patients come in clinging there, sort of, you know, holding on to their MRI reports and things for dear life, thinking that it's so important. And it is, but it's not important without the clinical picture to go with it. And it's much easier to sort of say it in person sometimes than do it in practice. But I think it's really important for us all to remember that and try and help explain to the patients that, again, you know, what's on wording on a report isn't necessarily what's giving them their pain. And again, that's an even doubly big reason why we try and only image if we really feel that a patient's going to, you know, potentially needing surgery or something here. So yeah, very much linking. So there's, you know, a huge amount of these changes are probably as normal for age as are, you know, gaining a few extra wrinkles or a few extra grey hairs, unfortunately. So pain relief modalities, analgesia, obviously NSAIDs, sort of ibuprofen, naproxen we tend to use. I think you tend to, and we can have a talk about that, maybe ask Alex a bit afterwards. I think you're still using a bit more diclofenac because that's what's available. Obviously there's the sort of weak opioids, so we use cocodamol if the patient's unable to tolerate NSAIDs. And I think there are some of the, Alex, you can help me here afterwards, you know, some very small doses or short doses of some of the diazepams or something. But then obviously more physio-wise, sort of a bit of manual therapy, so hands-on manual therapy. We use acupuncture here in the UK. We don't tend to use electrotherapy as part of a package, but for us it's any, and I know unfortunately but some of what I've observed in your physio clinics might be a little bit more passive than what we would now do in the UK. But actually the passive treatments, they're not bad, but it's really about, does the patient understand that we're doing that to enable movement? And actually it's movement is the treatment, and the pain relief modalities are really to allow movement. It's all about getting the patient moving, which then brings me on to Dorcas's question of corset or bed rest, of which, unless any of you can think of something that I haven't thought of, or is my thoughts on corset or bed rest is absolutely, and obviously this is where your situation is different to ours, but I can only think of if there's an unstable fracture until adequate fixation is acquired, whether that be surgical or through natural healing. And without that fracture, I can't think of anybody who should be in a corset or on bed rest. So has anybody got any contradictions to that they want to put into the chat? Because I'm very aware that, you know, I'm saying this here from the UK, and obviously you guys are, you know, in Kenya, and you're aware of what services you've got and not got available.
Hello.
Hi.
Hi, I'm Dr. McKenna. I'm a final year resident, orthopedic surgery. Can you hear me?
Yes.
Hello, you can hear me?
I can.
Okay. So acute muscle spasm, like for example, the second patient that you mentioned, day one had maybe a strain, was trying to lift something heavy, felt a pop or something happened at the back. We're not able to walk, not able to move, not able to do anything. Rushed to hospital. Imaging, everything is normal. That first day, 1 day, 2 days of rest as the inflammatory process goes down, and no corset, but rest. I'm not talking about a corset, I'm talking about bed rest. And then maybe you can start moving around by the 3rd, 4th day, and then some range of motion exercises after that. That's what I would think, maybe for the intensely acute muscle spasm or back pain.
Yeah, I think with that, it's the rest will come naturally, because the patients will actually be in too much pain to be moving around too much. But the essence of prescribing bed rest, I think the answer is no, because it's prescribing to the patient to try moving as much as you possibly can within the limitations of this pain that you've got. But, you know, do try and at least get up to go to the bathroom, you know, when required, even if you have to crawl there. It's just some essence of encouraging the patients to move if they possibly can, understanding that it might take 2 or 3 days to get going. So just rather than prescribing the bed rest. Would that make sense?
Yes, a lot of sense. Thank you.
Yeah, no, that's okay. So I'm going to move on so that we have plenty of time for questions at the end. And I want to, so yes, the concept of a corset is we've got one. We've all got them. They're called our abdominal muscles, our diaphragm, and I think really importantly, especially for the women, but also for men, is the concept of pelvic floor. Lots of people, particularly obviously lovely women in Kenya, lots of lovely babies, but that does mean they've usually delivered lots of babies, and there's the weakness of the pelvic floor. And the concept of pelvic floor exercises, Kegel exercises they're called, can be hugely useful to that sense of a muscular corset around your back. And in fact, that's one of the things that I did remind and go through again with that patient, who was actually a mum from 11 years ago, but still has sort of abdominal muscular tone, and her ability to recruit her transabs right down deep was definitely limited. So that essence of this being part of the exercise that you can get doing, and you can do your pelvic floor exercises and static abdominal work at the point of acute pain, because you're not actually inducing movement with that. It's very much about that contractual hold in a still position. And then just moving on, so here's just a few little exercises: knee to chest, pelvic tilt, knee squats and lunges, because having good quads, one thing I really notice when I come actually and demonstrate lots and lots of squats. I'm afraid to say huge number of the population of Kenya, Dorcas will laugh because she'll have seen me demonstrating squats, but it's not brilliant, would be my point of view. But I think the main thing I'd say to you is don't feel that there's any specific exercise which has to be prescribed, because it's about the concept of movement, whether that be gentle walking, whether that be changing in position, whether it be doing something, is more important than it must be this exercise or it must be that one. Yeah. I've talked enough. Alex, have you got anything to add at this point from what we've said so far, or anybody else?
No, I think yes, relative rest, but yeah, get moving as soon as you can. Take the analgesia on board, and the sooner they move, the better. And often it's about reassurance. It's nothing serious. It's very painful, very sore, but nothing to be overly concerned about. Try and get moving as soon as the pain relief kicks in.
Yep, great. So that's, yeah, I guess that's for your sort of acute back pains, but very definitely nothing with any sort of ridiculous symptoms or anything that is going to suggest that it needs a sort of progression in treatment up towards imaging or surgery, which is huge. Obviously that lady was younger. What I haven't necessarily put into this is the concept of the older person who comes in with back pain, most likely obviously to be a sort of OA or a stenosis, but I think it's similar in many senses of gently encouraging them to keep moving, encouraging them to keep strong. The only difference actually at that point is with the sort of osteoarthritic patients is sort of sitting or giving them bending exercises actually could be wonderfully helpful, because it opens up the facet joints at the back, which of course are causing so much of that sort of OA based pain, whereas maybe for somebody younger you're encouraging them to keep upright a bit more to and sort of keep moving. But again, it's got to be patient specific, but that, yeah, so it's just the concept of thinking about the subjective of what it was that they'd done to the back and who the patient is when you actually make those recommendations. So we're going to move on. So case study 3. So again, these are all patients that I've seen this girl this year. So 34-year-old female, job involves sitting. She's a call center sort of on the telephone a lot, very active and sporty in her spare time. BMI approximately 25, so not overweight, particularly, obviously might have a little bit more tone, but certainly within the realms of healthy and normal. One day she remembers lifting something, leg pain. She remembers really specifically saying to me, I could not sit down, or actually what she wanted to do is sit in a real bucket. What she couldn't do is sit on a sort of normal chair with any sense of sort of extension within the sitting position, but yet she could almost go into a complete bucket. So she quite liked it in some senses when she was giving her back some gapping space. Anyway, because of COVID, she had a real delayed access to physio. She hadn't seen her GP, although I think she might have spoken to the GP on the phone and been given some painkillers. But I'm sure you've had it in Kenya as well. But we've had a massive hit to the sort of the other any other healthcare condition and access to healthcare professionals. So she eventually came to me through an occupational health. She was still very limited in her ability to flex down and touch her toes, in the sense that to do that she had to bend her right knee really quite significantly, and more so that you'd expect. And her straight leg raise was about 40% of the other side. So I saw her 4 times as you do. That's what I had. It made a tiny bit of difference. Didn't make a huge amount of difference with a bit of manual therapy, giving exercises, giving advice, giving acupuncture, but no real change. And I was almost certain that this was discogenic, probably to the point of a bulge that might well require some intervention. If she'd come to me at 6 weeks, the outcome would have been to still wait longer, because an awful lot of those would settle. But at 6 months down the line, it was very obvious that this hadn't settled, hadn't made any changes by my input. And so I wrote a letter to her GP asking for her to have a referral to the spine team up at the local hospital. And I think I feel here that, the GP, based on my recommendation, made that referral without seeing the patient. So again, I was very fortunate in the fact, maybe it's what I wrote, but it's that element of trust that as clinicians, you know, we are able to give a really sort of comprehensive picture of the patient. And then this is partly why I've asked Alex to be here, because actually Alex, as the physiotherapist, was the clinician in the spine clinic who saw this patient and agreed she needed an MRI, which has indeed shown a bulge, and she's now on the waiting list, actually not quite yet for the microdiscectomy, but on the waiting list to see the surgeon. And I think this sense of a pathway, it's the concept that you don't actually get in the surgeon's doors until we know that you need a surgeon. So if I go forwards one, Alex, do you want to come in? I know this is going to be rather small, so you might have to describe through a bit more what happens rather than get everyone to read.
Yeah, sure. Thanks, Alice. So essentially, this is the pathway that we have here in Plymouth in the UK for referred patients who have got back pain, who have got radicular pain, sciatica. There's a triaging criteria for the length of time they may have these conditions and what they should try. But essentially, the GP can refer the patient into a local physiotherapy service, or they can self-refer, and they either get better with the care that's given there, or if there's any concerns about something like cauda equina, they would be referred off to the emergency department to be treated there and then, and dealt with as appropriately needed. So beyond the actual physiotherapy therapeutic care, the pathway, I suppose, starts where GP referrals, some in-house orthopedic referrals, rheumatology referrals, but generally it's GP referral into a lumbar spine pathway. The referrals are triaged to ensure that it is lumbar spine pathology and not cervical spine or thoracic spine. We do see thoracolumbar, we do see lumbar sacral, a few coccyx, but in general it's lumbar spine. And they will be then asked to come to a clinic for a full therapist who essentially will do a full subjective, objective assessment of their lumbar spine, including some psychosocial element to it to understand how they feel about it, and what they're looking to get from the appointment, what they're expecting, whether they're keen to have any spinal surgery or not, because that allows us to know whether they want to be put in front of a spinal surgeon or not. What they feel about their symptoms, how long they've had them, how disabling it can be, and then allows us to then decide on what we should do for them. So invariably, we've got the choice of referring for further physiotherapy if they haven't had sufficient, or we feel it's necessary. We can refer for MRI imaging under our protocols that we've got with the neurosurgeons. We can refer for CT imaging, X-rays, and nerve conduction studies. We can refer directly to our pain management service, which are looking at essentially it's chronic long-term pain. So patients that have had a few goes around and are still in lots of pain, then they would be referred to sort of the chronic pain team for either medication review, one-to-one treatments, group therapy, pain management programs, or denervation of nerves, or even nerve root blocks if required. We can refer obviously to the rheumatologists or the orthopedics if it turns out to be more of a rheumatology or a hip problem or a knee problem. They can go there. And then on the back of those sort of investigations, they'll come back to us. So we're in charge. We need to follow those investigations up. So an MRI will come back to us. We'll have an MDT with the neurosurgeons discussing the assessment, discussing the MRI, and agreeing whether there's a surgical target or not. And on that occasion, it may well be, if the timescales fit, that a nerve root block might be appropriate. If not, then we'll refer on to see a neurosurgeon directly, or we'll discharge from there. So the expensive neurosurgeon with the skills of doing the neurosurgery only gets to see the patient that needs neurosurgery. Everything else is put into the right place to see the right person at the right time. Now, in some circumstances, obviously, there are patients we will see that will get imaging, but from the outset, it's never to offer them surgery. It's to offer them the chance to be reassured that there's nothing in their spine that they should be continually worry about, in the hope that we can progress them then on the pathway to conservative management or pain management to enable them to move forwards and get on to recovery. Essentially, there's quite a bit of anxiety in the UK that if we haven't seen it, then how do we know what's going on? So part of what we do with an MRI scan on occasion, not all the time, is to reassure the patients that we've scanned their back and we found no cause for their problem, so we can then try the next part of the therapy pathway. And then it's essentially going around those sorts of treatments until we get resolution, or the patient comes to terms with what they've got and can manage moving forwards. And that would be the kind of the exit of the pathway from there. So it's ensuring that the clinicians in the pain management team, in the rheumatology team, orthopedics, the neurosurgeons, the spinal surgeons are all getting to see patients that they're fully paid up to see, and not lots of other conditions which they're not going to be able to help with.
Yeah, great. Thank you. Has anybody got any questions for Alex at this point, or shall we wait and come back to those at the end? Should we move on? Yeah, we'll move on. We'll come back to you at the end. So actually, there's just the next couple of slides were really just this sort of patient's MRI. That's obviously at the 4-5 level, and then you can see the bulge down at the L5S1 level. So fortunately, on this occasion, I was completely right in realizing, and Alex completely right in realizing, that we needed to this patient, I'm fairly sure, is going to need to see the go for surgery to be able to recover. So, but if she wasn't, or while we're waiting for that, just management of sciatica, obviously to continue to monitor for red flags, never assume that it's obviously pathology is not going to change. And then, I haven't actually come in with any details on this stratification tool, but there is a sort of essence of assessment of being able to work out whether a patient, from their levels of anxiety, levels of description of their fear of movement, their dependence on analgesia, that sort of thing, whether they're likely to end up quite disabled with back pain, or whether actually they're an individual who will have this sensation but actually very much gets on and lives life. And actually probably by that way, there are tools that can be used to help identify possibly the sort of psychosocial aspects. And I can give you links to that. So obviously adequate analgesia, information about time frames, and again, back to the staying active and resuming normal activities as possible. Those of you that have worked with me in Kenya, obviously the concept of group therapy, back pain classes, or it's not even the concept of back pain classes, but almost just activity classes, to really encourage people that it's not dangerous to keep moving despite the fact that you might have some pain. And then obviously potentially refer to surgery and pain clinic, as we've indicated, if it's a little bit different, but again, similar to that, the same pathway that Alex just talked about there. So this is another patient who I had in the other week, male, 48 years, BMI of 26. So he's an active job as a firefighter. He'd had a previous microdiscectomy of the sort of the L5S1 nerve root compression, and then he'd also had another episode of acute leg pain. But it being the front of the thigh and leg, and he described it being really very severe. He'd gone to ED, he'd required morphine, had been advised analgesia and movement, had stayed in a lot of pain for 3 months, was off work, so obviously got referred up to the spine team. And this is where his MRI showed that he did have a broad-based bulge of L4, L5, but there was no nerve root compression at all, and therefore no indication of surgery. But ultimately, there's a huge amount of sort of fear of the sort of psychosocial issues, of not wanting to return to function, of fear of movement. And this comes sort of much more back to the long-term essence of how you educate patients in chronic pain, support them in chronic pain, to get going either by ourselves as physios or again with a sort of multidisciplinary team for a holistic patient-centered package in the pain clinics that Alex talked about. So a patient who'd gone up to the hospital in the same spinal pathway, but obviously a different outcome of having the MRI, but as much to show that actually surgery wasn't going to help him again in this particular case. And then just wanting to just come into this, the sort of prognostic factors for pain chronicity and low back pain. So this was a systematic review. Admittedly, I think it's mainly literature from the US, the UK, or certainly the sort of northwestern parts of the population, the global population. But this, global point prevalence of activity limiting low back pain for more than one day is about 12%. Most improve rapidly, with improvements in pain and disability within a month, but up to about between 4 and 25% develop chronic pain, which, if we think back to those numbers originally, hence there's a huge number of people living with sort of disability affected life years based on back pain. But it had, even from the 80s, talked about the prognosis of what we call non-specific low back pain is massively influenced by factors not related to the actual anatomical structural basis of the spine. And this particular article was about reviewing that. So it's all about, this is where we talked about that stratifying, but the sort of concept of a higher pain intensity at the side, higher body weight. And I'm afraid to say, when I'm observing a lot of the patients when I'm in the Kenyan clinics with back pain, I know it's really hard, but there's quite a lot of overweightness, carrying heavy loads, difficult working positions, sort of depression. These would be very different for you in Kenya, and possibly, as an area of research, looking at what the prognostic factors are for you in sub-Saharan Africa. So I don't want to put this, this is all where all the evidence has to be read in the context of the local situation. I think this fear of movement in the acute stages is huge. And is what really brings us back to that sort of communication with the patient's reassurance. And if in doubt, what to tell a patient who's got back pain, I think the and pain management and it being patient-centered, but about encouraging the patients that movement is not dangerous and that the individual is incredibly unlikely to do anything within normal function to create any structural damage. And it's much more likely actually to include to improvement and less pain in the long term. And those are some of the references, and I can email the slides over so you've got all of that. Any questions? We allowed some cameras on so we can see you, lovely, lovely people from Kenya. There's a couple of questions here. Should we go through them? One is on adjustable office tables, and I don't know if you noticed, but I'm standing up talking to you here because I'm very lucky. I do have a table that goes up and down, and I would say if you've got an office job, and I do a lot of my education from my desk here at home now in the last year, yes, not sitting down all day makes an enormous difference. So Alex, can I pass this one to you? What's your experience with alternative modalities such as acupuncture?
Yeah, so as a clinician, as a physiotherapist, I've used it for back pain. I've used it for radicular pain, both cervical and lumbar. And for some patients it works. I can't tell you why it works or how it works, but for some patients it does. But through our national guidance, our NICE guidelines for low back pain, we're not allowed to offer it for sort of back pain or radicular pain because the evidence didn't stack up to the criteria they wanted at the time of going to press for that.
But that's within the NHS though.
Yes, however, that's the NHS, and that's within my role as an extended scope physio, I wouldn't be able to say to patients that's what you should do. However, having experienced it with patients as a physio and as a private clinician, I do give it, and it does benefit them. So it depends on how you feel about criteria and national guidelines and the evidence used for it. But certainly, I think there's an avenue to explore for all the alternative therapies, because some patients really benefit from all of them, any of them, some of them. Some patients don't, and if it works, then I think it's beneficial, because pain's horrible. Life is miserable when you're in pain, and if you can find anything that helps you, that's not causing you any harm, then I think that's worth trying.
Yeah, thanks, Alex. So I think that actually comes back on to Barry. Your question is about sort of experience with intermittent traction. So we used to have traction beds that were used in this country, and you sort of, attach the patients up and you tried to stretch them, whether you actually managed to stretch them or not, or whether it was a bit of a sort of soft, who knows. So we don't use them here anymore. I think, again, if a patient finds it helpful, it's available, it's not going to do them any harm. I think you just have to question the effectiveness. But I think the effect is in probably reassuring the patient a bit, to the point that it enables them to move, and it's the making sure the patient knows it's the movement afterwards is actually what's getting them better, not the traction. I don't think there was really incredibly, Alex, tell me if I'm wrong, I don't think there was any evidence behind mechanical traction, was there?
No, as you say, it's all gone out. I mean, the evidence at the minute is pretty much exercise, and when you've done the exercise, do some more exercise. It's all about movement, pain relief. Heat is good, absolutely. Muscle relaxants are good in the short term, and then it's just to get over that initial hump of acute pain and try and get them moving, get them engaged in moving, get them happy and confident in moving again, which is often the biggest battle.
Yeah, absolutely. So then there's a question here from Peter about the role of chiropractic and chiropractic. I think my view, again, Alex, tell me, is ultimately it's another form of manual therapy. Chiropractors do manual therapy. Manual therapy in theory is a pain relieving modality. I think, again, the question is, are you making a patient passively dependent on a passive manual technique, which has got less evidence than actually than doing the manual therapy to tell them about all the exercises, and so that they go away and do the exercises the other 7.5 days or 6.5 or 6 days and 23.5 hours of the week that they're not having the chiropractic sort of treatments in for. But it's some people's businesses, and therefore there's an essence of what's good business sense versus actually what's the evidence for what's going to get the patient better.
Yeah, so I agree. I think with all therapy, it's got to be active therapy that gets the patient engaged and actively looking after themselves, not a passive bystander. That will never get anybody any better being passive. They need to be a fully active, engaged. So if a chiropractor is giving them good exercise advice alongside their hands-on treatment, then brilliant. Same with an osteopath, brilliant. They've got to have something in between, as you rightly say.
Yeah, and I think that's one of my questions, in the sense of, I know even with your government hospitals, the patients pay a bit for the physios, but is it just paying for the passive treatment, or is it paying for that advice and education on really what they can do at home to get themselves better, and just ensuring that the evidence is there, really for the patient experts to come in and be the right. Great. So yes, Jeff, use of hot packs, yeah, great. But a patient can be taught how to do that at home with a hot water bottle. That doesn't need to be a coming in for a sit in a therapy clinic for 20 minutes because there's anything special that happens in a hot pack. Alex, I'm going to send this one to you. That sense of a CR, so guided facet joint injections. Is it still practiced in degenerative lumbar problems here?
We do. It's generally done within the pain management setting. We don't operate on back pain purely, so we only really operate for radicular pains. So any sort of long-standing chronic back pain would be offered a epidural, probably a medial branch block, or a radio frequency denervation. Beyond that, it's oral analgesia or patches, and then your TENS machines, your acupuncture, and all the other stuff that we've spoken about.
Yeah. Yeah, and then there's more coming in here. So Alex, I'm going to pass this one back to you actually, as your ESP role. Common prescription habits in terms of analgesics, muscle relaxants, and neuropathic drugs.
Yeah, it does vary quite wildly, but the GPs around the area would offer diazepam as a muscle relaxant, just maybe no more than sort of 7 tablets. They give a very short script on that. Then the go-to is ibuprofen as an over-the-counter medication, and paracetamol. And then the GPs do prescribe the naproxen and omeprazole to look after the stomach. Then the ladder kind of goes through cocodamols, tramadols, and then if it's a nerve type pain, they'll go to the neuropathic pain agents at the minute. So amitriptylin's the cheapest one, so they start there, and then nortriptyline, gabapentin, pregabalin. And rarely, but on occasion, you will see people that are on Oromorph or those sorts of things. But that's in general what's being used. The pain clinic would look at tapentadol as a medication as well, but that's generally what's being used over here at the minute.
Yeah, thank you. So there's there's a couple others. Might come back to, yeah, malingerers and insurance compensation issues. We do have them, less than I think we used to. I think that essence of treating it properly at an acute stage, and not that it ever didn't. There are some, but you can usually as clinicians work it out because they don't respond appropriately to what you're suggesting. But anyway, Alex, any other thoughts on that?
Yeah, I mean, they're around. They tend to drift mainly up towards the pain clinic. Yeah. And they've kind of had the whole battery of treatment and investigations, and it's hasn't been able to find a just cause, and so it's left the sort of self-management medication, and generally managed in the community with the GP practices. Yeah,
it's hard, but at the end of the day, you do your bit as a clinician, I think, and at that point, you sort of obviously have to move on a bit.
Absolutely.
Yeah. So yeah, TENS, the nerve stimulators, again, they're there as a pain relieving modality, so they can be quite useful. They're cheap. The patient can own them themselves and use them. Certainly in this country, obviously, it might be slightly more expensive for you, but again, it's very passive. What's really making the difference is actually it's just another form of analgesia, and it's all about getting the patients moving. So I think that is the key thing with all of these. Is it this modality that's making the difference, or is it the pain relieving effect that's getting them moving which is making the difference? And actually, what is the best, or what is an effective pain relieving approach that the patient can do themselves? And often therefore that's heat, or that's a bit of analgesia at home, or actually it's just getting moving, because by getting moving you'll treat yourself and act as a pain relieving modality to move a bit more. And that's really been the key thing that we found over the last 10, 15, 20 years here, that you know, where we've really moved on from pretty good. Radiotherapy, that's way outside my speciality, so not going to talk about radiotherapy. Back pain in COVID-19 isolation wards. I haven't been in the COVID-19 isolation wards. I don't, Alex, anywhere. And obviously there is long COVID, but any awareness of situation there?
I'd imagine that COVID overtook any other problem they had, so they dose them up with pain relief and leave them alone, I would have thought. Yeah, but no, I haven't even been anywhere near it, so I don't really know. But over here, it's certainly been very much COVID, and anything else you got, we're not really overly concerned, because COVID's our main
Well, I think ultimately the respiratory system has to come above the neuromuscular system, doesn't it? So, well, obviously musculoskeletal system in the sense of priority of care.
Yeah.
But I know, again, with COVID patients, a lot of proning, which might help, because actually proning is a very good position for back pain rather than always being on your back in a bed. So at least regular turning probably actually helps patients maybe not get some sort of bed rest initiative. And then there's been a lot of rehab of getting even patients in intensive care up, walking, even ventilated, so ventilated walking. There's a rehabilitation garden, so outside the intensive care unit here in Plymouth, which had at one point 30-40 beds, patients, even if they were still ventilated, were actually not ventilated maybe, but at least on CPAP, taken outside, into the fresh air and up on their feet. So it's very active care, and the sense of physios and occupational therapists being in ITU is now a massively considered important part of ITU care. Anything else?
Yes.
Peter.
Yes, I can see. Just a minute. Oops.
Oh, I can see a question from McKenna.
Yes, there are a few other questions.
Yeah. Do you want me to have a look through? The question to do with the radiotherapy, I think probably is maybe just outside this particular sphere, because obviously post chemotherapy, radiotherapy for cancer, and the pain that you get following that is very different to the sort of the concept of back pain in a musculoskeletal sense that we're talking about. So I'm afraid I don't have the expertise to comment on that at all. The role of an inverter in pain treatment, is that where you turn upside down? I haven't ever tried one of those. I'd quite like to, if you've got access to one. Managing back pain through telemedicine, I've actually done quite a lot. I've still seen patients, but friends and family over the years, it's not the same, but it's you can give the same advice. You can watch somebody moving or not. Actually, Alex, in the NHS, you've probably got much more experience of this during COVID than I have.
Yeah, absolutely. So it is trying to gain some semblance of how they move, and then offering the sensible advice, taking on board what they feel that the insult or the injury was, or whether it's an insidious onset type of thing, and then just giving some sensible advice on managing pain and gentle movement, relative rest as required, and then getting going, really. So it can be really good. I mean, a lot of reassurance goes a long way for lots of these patients. If they know that there's nothing serious, sinister, or life-threatening, they do tend to recover pretty quickly. So it can be really helpful. More helpful with a video call. We've been doing a bit of video calls, so you can actually see them and build a bit more rapport and get a good idea that you're both talking about the same thing. But it can be done, but it's no substitute for actually being in the same clinical space as somebody. But when needs must, it can be done.
Yeah, and actually I'm going to come to the concept of the same clinical space in a different aspect, actually. So not just having the patient in the same clinical space as you, but there's a question here about orthopedic surgeons. How would you advise the orthopedic surgeon to prescribe physio for your chronic degenerative low back pain? And I'm actually going to throw that back at you and maybe ask Dorcas or Catherine if she's there, or even Dr. Nadania, who've worked with me. But actually, I would like you to really consider how you might bring your multidisciplinary team or your physios or somebody out of their departments and rooms and into your clinics. Because the best way of prescribing physio is not to prescribe it, but is actually to have those clinical discussions in a room, understanding what you want and what you don't want and who can offer what. And I don't know, Dorcas, you've worked with me, and how we've had that sort of interaction. I've scared her off.
Okay. Thank you very much, Alex and Alice. Very close two names for your wonderful presentation on a subject that is usually very difficult for all of us. And the questions that are coming tells you that how difficult it is to manage low back pain. I wish to thank the two of you for taking time to be in Kenya on Zoom and welcome you again at another time. I also wish to thank our members. There was a record attendance of over 80 of us.
Yeah, thank you, Peter. It's been lovely to be able to have this opportunity to talk to you all.
Hello, are you hearing me? Hello. So thank you very much and have a good night.
Thank you.
Alex, thank you very much.
Pleasure.
Thanks, Alex.
No worries.
That's right. Dorcas, are you there? Don't run away.
I'm still here. I think we'll discuss that maybe next time. The last question you asked, I think we'll go through that next time.
Speak to you. Thanks for joining. Speak to you soon.
Okay, thank you very much.
I'll WhatsApp you. Okay.
Okay, good night.